Hi, we are representing Carroll University's Master of Science in Clinical Exercise Physiology program. The researchers of this data are Genevieve Meintz,
Emily Kana,
Pancaditis,
Sarah Jesse, Gina Guidarelli,
and Wyatt Miller.
We have been working with and mentored by Dr. Jessica Brown and Dr. Daniel Shackelford as we have collected data for this research throughout the past few years and appreciate you taking the time to listen to our research. Our research provides evidence that the Shackelford protocol elicits more VO2max criteria than modified Bruce and Balke-Ware in cancer survivors.
treatments and toxicities associated with cancer and its treatments can cause detrimental effects on physiological functioning, especially cardiovascular functioning. Cardiovascular function can be represented using a graded exercise test measuring maximal oxygen consumption, or VO2max. Determining detriments in performance, both functionally and physiologically, plays a major role in the development of an individualized exercise prescription and provides more information regarding the detriments associated with cancer and its treatments.
Figure 1 shows the detriments that cancer survivors undergo. Some of the main toxicities that a cancer survivor may have undergone are cardiovascular toxicities, musculoskeletal impairments, neuromuscular toxicities, and cancer-related fatigue. The arrows next to each of these toxicities will show the effect of the toxicity and whether it increases or decreases. The primary determinant that we focused on was a decrease in VO2 max. These specific treatments, like anthracyclines, which is a type of chemotherapy drug, and radiation to the chest area, can potentially affect the heart muscle, leading to these detriments. Another potential cardiovascular toxicity is going to be decreased cardiac output, decreased ejection fraction, decreased stroke volume, decreased contractility, and left ventricular dysfunction. Next, neuromuscular toxicities can manifest in multiple ways. Chemotherapy drugs, such as platinum-based drugs, can cause peripheral neuropathy, as the drugs can damage the nerves outside the brain and in the spinal cord. Neuromuscular detriments can also present with decreased balance and gait disparities. Surgery and radiation often affect coordination and joint mobility. The coupling of these different types of treatments and their effects often lead to an increase in falls and balance issues. Chemotherapy and hormone therapy treatments can also negatively affect the thyroid function, which disrupts hormone production. Chemotherapy, radiation, and surgery can also affect muscles, bones, and joints, leading to muscle weakness, joint stiffness, limited range of motion, and bone density loss. These treatments disrupt the normal processes of protein synthesis, increasing protein degradation, resulting in cancer cachexia. This can lead to decreased muscular strength, endurance, power, and a decreased estimated 1 rep max. Cancer-related fatigue is the most reported symptom of cancer treatment, which is unrelieved by rest and makes ADLs and exercise motivation challenging. It commonly affects mood, concentration, overall well-being, and negatively impacts quality of life and can often lead to depression. Cancer-related fatigue also limits exercise capacity, as cancer survivors are commonly fatigued prior to starting exercise.
As discussed previously, cancer survivors undergo treatment that causes physiological detriments. These changes may lead to the cancer survivor being unable to maintain higher intensities in both speed and grade. Figure 3 best illustrates this point. The modified Bruce utilizes drastic increases in both speed and grade throughout the protocol, reaching a total net value of around 20. The modified Bruce, which is highlighted in black, utilizes drastic changes in speed and grade. This protocol is also commonly used in stress testing due to the length of the test. However, it may be too difficult for some clients because of the vigorous starting intensity. The Balke-Ware, highlighted in purple, was originally used to test the functional capacity of healthy military personnel. It utilizes a more gradual grade progression, but has a consistent speed of 3.5 miles per hour, ending the treadmill protocol at about 12 METs. Individuals without chronic diseases or side effects may be able to tolerate a speed of up to 3.5 and adjust their gait and walking speed accordingly. However, this brisk and constant speed may be unsuitable for cancer survivors due to neuromuscular and all other toxicities previously explained. For comparison, the Shackelford protocol, which is highlighted in orange, was originally developed for cancer survivors. It starts around 1 MET and every minute increases in both speed and grade, in smaller increments, allowing participants who are suffering from cancer toxicities to go further in the test and thus reach a higher and more accurate VO2 max. This protocol ends around 15 METs. Exercise is able to offset many cancer toxicities, but in order to do so, an accurate exercise prescription is needed. VO2max often dictates exercise recommendations, where using the correct protocol to elicit a true VO2max is crucial. Despite the development and validation of the Shackelford protocol, the Balke and modified Bruce are still used for cancer survivors. Therefore,
the purpose of this study was to determine the treadmill protocol that creates the greatest physiological response while accounting for toxicities associated with cancer and its treatments. We observed the differences between the modified Bruce, Balke-Ware, and Shackelford protocols in their ability to elicit the most maximal criteria in cancer survivors. For our research, we had 45 cancer survivors complete 3 maximal treadmill protocols totaling 135 graded exercise tests. Inclusion criteria required a participant to be diagnosed with cancer and be at least 18 years of age. Type of treatment and cancer were not limited in this study as it was looking at the general cancer survivor population. We used gas analysis via a Cosmed brand metabolic cart to obtain respiratory rate ratio. Other vitals such as perceived exertion and heart rate were documented. One treadmill protocol was completed once per week for 3 weeks, with at least 5 days of rest in between each test. Each cancer survivor was randomly assigned one of 6 protocol treatments, performing the Shackelford, Balke-Ware, and modified Bruce protocol. A Cochrane's Q statistical test was used to compare total max criteria obtained between protocols, and the significance was set up at a p-value of less than 0.05.
In our study, we had 12 males and 33 females, ranging from the age of 21 to 81. Before each cancer survivor started their first treadmill protocol, we collected weight, height, and medical history, including cancer stage, cancer type, and treatment types. The height of the survivors ranged from 57.5 inches to 74 inches. The weight of the survivors ranged from 97 pounds to 243.2 pounds. Of the cancer survivors participating in our study, 29% reported stage 1 cancer, 9% reported stage 2 cancer, 33% reported stage 3 cancer, 13% reported stage 4 cancer, 4% recorded stage 0 cancer, 2% reported Gleason 6, 2% recorded Gleason 7, and 7% reported unknown stage of cancer. Of the cancer survivors participating in our study, 36% reported breast cancer, 13% reported prostate cancer, 9% reported Hodgkin's lymphoma, 7% reported ovarian cancer, 7% reported uterine cancer, 4% reported lung cancer, and 1 cancer survivor was recorded for each of the following: colon, multiple myeloma, tongue, gastric, brain, rectal, leukemia, carcinoma, colorectal, and kidney cancer, totaling to 24%.
Our results demonstrated that the Shackelford protocol elicited significantly more VO2max criteria than the Balke-Ware or modified Bruce. Significance is 0.002. As the Shackelford produced VO2max criteria 89% of the time as compared to 75% and 81% of the time in the Balke-Ware and modified Bruce. Regarding RER, the Shackelford protocol elicits an RER of 1.1 in 89% of participants as opposed to 76% and 73% in the modified Bruce and Balke-Ware. An RPE of greater than 7 was reached in the Shackelford 93% of the time, in contrast with 89% and 82% of the time in other protocols. Furthermore, max heart rate was met 87% of the time in the Shackelford protocol, rather than 80% and 71% in the modified Bruce and Balke-Ware. Additionally, there was significance between the Shackelford and Balke-Ware for all termination criteria measured, significance of 0.03. However, no significance was found when comparing termination criteria in the modified Bruce and Balke-Ware. Significance is 0.302. Significance is shown with the B symbol as well as the asterisk.
Cancer toxicities can cause physiological detrimental effects such as musculoskeletal impairments, cardiovascular dysfunction, cachexia, gait disparities, balance issues, peripheral neuropathy, and cancer-related fatigue. These toxicities are not accounted for in the modified Bruce and Balke-Ware, as they both increase quicker and are more intense at each stage, often leading to early testing termination due to non-cardiovascular reasons such as musculoskeletal fatigue, reliance on anaerobic systems, and rapid accumulation of physiological byproducts. The Shackelford protocol, due to its gradual progression, is the most appropriate protocol for cancer survivors as it clearly elicits cardiovascular fatigue. The Shackelford protocol remains a superior protocol for cancer survivors as it accounts for the physiological detriments of cancer treatment. Thank you for taking the time to listen to our research study. We want to give a special thank you to Dr. Brown and Dr. Shackelford for taking the time to teach and mentor us for the last 2 years.